Hello, everybody who may be joining me in person or asynchronously. I'm Jenica Siddle. I'm an emergency doctor in Greenville, South Carolina at the University of South Carolina, Greenville, and Prisma Health, where I practice. And I'm going to go ahead and drop in the chat, first of all, some of the resources that we're going to use later today, about halfway through my presentation. And then I'm going to go ahead and start sharing my screen and we'll get started. So I appreciate the invitation today from SAEM and the Academy of Women in Emergency Medicine as well. I am representing my team. I'm Jenna Cassiddle, as I mentioned, but I'm representing my research fellow Zoe Garceau Tremblay and our associate professors Kelly Cannell, Mary Rojak, and Dr. Allison McGregor, who are also part of our team at USC Greenville. And I'll be telling you about our exciting research and teaching you that sex and gender is everywhere, and we're going to put it to work in your academic practice. I have no financial disclosures. I do want to recognize that this is research that was supported by the NIH R25 Research Education Program grant that we received about 2 years ago, and that my international research fellow, Dr. Garceau Tremblay, was supported by her university in Montreal to research with us in the last year. Our learning objectives today, by the end of this session, what I expect is that you'll understand and be able to discuss the historical context and the need for integrating sex and gender into emergency medicine and medicine in general, that you'll be able to use our new validated NIH-funded sex and gender curricular assessment revision toolkit and have some practice with that today. And you'll also be able to develop strategies to help incorporate sex and gender content into existing emergency medicine teaching materials. So we have to start at the basics and make sure that everyone's on the same page. What are sex and gender? Every cell in your body has a sex, and every person has a gender, and both have an impact on health. And unfortunately, you'll see even in our scientific community and at large in society that people will use these two terms interchangeably. So I like to make sure we're on the same page since they're actually separate concepts, but both matter. Sex, we consider a biological variable, and we're talking about sex chromosomes, sex organs, and hormones, which differ in males, females, and intersex individuals. Now, it's not all binary. There's a remarkable number of disorders of sexual development that make things somewhat different at times, but we like to recognize that this is really that biological variable and that the preferred terminology when you're representing this is males, females, or intersex. Gender, on the other hand, is more of a sociocultural variable. It's really what society constructs around you and how you move through the world with your roles, your behaviors, your expressions and identities, power differentials that exist between men, women, and other gender minorities. And this can vary across different societies. It can vary across time, but it definitely has an impact on the way that people access healthcare. And it can affect the care that they are provided, the diagnoses that are considered, the seriousness or the timeliness in which complaints are heard or interpreted, and even how the gender of the healthcare providers interact with the gender of a patient. So what happened? Why do we have this confusion still, and why is it hard to talk about? So sex and gender, they're used interchangeably, they're melded together. Sometimes they are divorced of each other, as if that can always happen. But we want to go back and recognize that it's not all of our fault. This has actually been something brewing over many decades, and we're still trying to overcome. And so if we go back to the 1970s with, ethical research guidelines that were adopted due to other horrible historical contexts for doing research against people's will, rules were made about excluding vulnerable individuals, or at least considering their protection, and that actually led to many women of childbearing age not participating in any kind of research, and same for children. Over time, the government and funding agencies have tried to mandate or encourage inclusion of women and minorities in trials for better representativity in research, and including in the 2010s, funding organizations were requiring the consideration of sex and gender in the research design. So as we move forward in the 2020s, we still have things that change in our society regarding research in this realm. And we're still trying to undo how we came to be with biased research and biased education. So here, just as an example, coronary artery disease and cardiovascular disease is one of our better realms of research and differences between men and women and male and female anatomy. But you can see that in just the last couple of decades, that orange line is showing data where women were not included in the research studies. The green line shows when women were included, and while maybe you're seeing that orange line drop, we're not seeing as much of the green line go up. So unfortunately, all right, so we're here again. Thanks. The last slide is I was talking about with our orange and our greens. Thanks for letting me know. So this is just the tip of the iceberg, and this is just on coronary artery disease research, which I can tell you is so much more dense on sex differences than anything else. So we have a long way to go. Now, in emergency medicine, I'd like to give us credit. So in 2019, we have a paper that looked back at how much sex and gender was reported in just the sample population in emergency medicine articles. And so 86% reported the sex and gender composition. This was a drastically improved finding because I believe 10 years before that, it was only about 30%. So we were kind of whitewashing or blind. 34% in this review used sex and gender in their study design, and so they were being intentional. They used it as a control variable about a quarter of the time, an independent variable a quarter of the time, and ultimately about 2% used it in their primary outcome. And so that hasn't changed too much. In the decade before that, only 2% were reporting primary outcomes based off of sex or gender differences. We'd like to see that better, but at least we're happy that there's some representation in emergency medicine and a lot of researchers in emergency medicine. And why it matters, and I'm glad you can see the graphs now, is because whitewashing everything, regressing everything to the mean, and not disaggregating your data can hurt everyone. In this example, this is females and males using naltrexone as a medication to curb the desire to use cocaine. So if you look at this for a minute, our placebos are there. It's a pretty good designed study. And if you would look at female naltrexone participants, that's that red line. What actually happened is while they were taking the study drug, they were using cocaine at a much higher rate than the placebo. Now, the black line below is male use of naltrexone while, on the drug and in the study. That's pretty shocking. And if you had not disaggregated this, you would have found no difference of the drug whatsoever. It would have looked just like the placebo there in the middle, when in fact, this medication could have had harmful effects for one sex and beneficial effects for the other. And this is kind of a research heavy discussion just because we're trying to undo some of the things that have happened and we're trying to create new knowledge. But how does it then translate to emergency medicine? So, as emergency doctors, and I'll be the first to admit that thinking about hormones, all I'm really thinking about is passing my step exams over the years as a student and a resident, and that the hormones have something to do with reproduction. But in my day-to-day activity in the emergency department, it's not like they were at the forefront of my mind. Whereas these hormones actually fluctuate and matter significantly over the course of the day and over the course of a lifetime. And they influence different disease states that people are vulnerable to, and they influence the effects and properties of medication. So surely we all know everyone thinks about women in the menstrual cycle, but you probably are only asking in relation to trying to figure out if your patient is pregnant or not. But if you're seeing a patient who's just had a breakthrough seizure, it might also clue you in as to why, because anti-seizure medication actually varies in the amount that's bound in a woman's body during the course of her menstrual cycle. And so there can be more breakthrough seizures potentially at the end of the cycle when estrogen is at the lowest and everything is dropping. You might also be wise to at least ask about exogenous hormones. It's becoming more and more popular. We're good generally as emergency doctors about asking about oral contraceptive pills, typically when we're trying to figure out if a person is pregnant, and also if we're trying to figure out if their chest pain is related to a pulmonary embolism. But are we asking our male patients about their exogenous hormone use? So, testosterone prescriptions that you can get online have increased dramatically over the last 10 years. And it looks like, based off of literature, that it has a very similar risk to potentiate blood clot and pulmonary embolism in the first 6 months to a year, very similar to OCPs. So we could be doing a disservice to our men by not asking them about hormones, or at least considering hormone use also, as well as our transgender patients. Whenever they are transitioning, the effect of their new hormones will actually change their creatinine and GFR to resemble and match their transitioning gender identity. So this can all have an effect on medications, and it can have an effect on the disease process. So I like to reiterate, like, oh yeah, hormones, they're still there. They're still doing things. They're still varying in women and in men, but they might have more to do with our patients than we recognize. Now, we'll also talk about sex influences and drug pharmacokinetics and pharmacodynamics, because let me guess, out of all of these medications that you see listed, I bet you've used at least one or considered or seen them on your medication list for your patients in the last week, and even the last couple of days. So, thanks to sex hormones and characteristics, labetalol concentrations can be higher in females. Propofol levels actually decline more rapidly in females. You may have to redose or sometimes give higher doses. Aspirin and warfarin may have higher plasma levels in females and make them at greater risk of bleeding. And antihistamines may clear slower, and opioids may actually have a slower onset and then slower offset in females. SSRIs reach higher plasma levels in females. And then for anyone who suffers from insomnia, maybe from all of our night shift switching, zolpidem has a lower clearance in females and is one of the few drugs that actually has recommendation from the FDA to start at a different dose based off of your sex. So consider that. It was leading to car accidents at a higher rate because people weren't clearing it. And then I like this example with TXA. Even when there are no differences in the efficacy of treatment, thanks the sex hormones didn't actually affect, there can still be disparities in the care that's received. So after the crash studies, they reanalyzed their literature for men and women outcomes, or male and female outcomes, and they found that TXA reduced the mortality similarly for male and female. However, women were much less likely to receive it, even with similar injuries. And the older a woman got, even less likely that she would receive it, despite it having equal benefit. So sometimes that gender might blind us and mislead us into treating people differently. And even before the trauma happens, sex and gender biases can influence the world around us. And so the way the world is engineered, and down to the way that they do crash testing for vehicles. Women and men are not physically built the same in our bone structure and then our muscle mass. Yet, for most crash testing, they just use a scaled down, smaller, less heavy version of a male dummy. And I'm pretty sure they're still using like a 65 or 70 kilo average person, which is less and less average. So here you can see this slide shows just all of the different or more likely injuries a woman would have as opposed to a man, just because of the way the world is built around us. So now what? Across medical school, and probably in your background in medical school and coming up, we don't realize that we keep teaching biases, or that we keep whitewashing. And some of that is because of the research, which didn't exist before. And then your textbooks lagged behind by, a decade or more. And also just because whenever we start teaching, we teach what we know. So in this picture, you can see our uterus living in a little tiny box next to the male. And that's it, we've got the endocrine organ and it's off to the side. But we could have a little bit more nuance. In a survey that we recently redid, and mirrors a survey from 2016. Over 96% of medical students agreed that they wanted to know more, that they felt that sex and gender medicine improves one ability to manage patients, and that 94% felt like we should be teaching sex and gender differences in medical school, but less than half had actually had any exposure to this in their curriculum. The same goes for emergency medicine residency. Residents reported usually less than 6 hours of consideration of what was different with men and women if it was outside of reproductive health issues. And emergency medicine trainees, 74% felt their current practice would have benefited from further training. Certainly that's where I came to this, is after I'd gotten through residency and embarked on a research and academic and community career, realizing I didn't know everything and I wanted to know more. So in our medical school, we're used to seeing a slide like this of a man gripping his chest. I don't know about y'all, but I think I've maybe seen two people having a heart attack that were like grabbing their chest in this way, and yet it's so synonymous. It's in all of the cardiovascular slides over and over again. I appreciate that his skin color is different. I like that. But sometimes we're reinforcing a stereotype that is actually pretty rare and then labeling other symptoms that are more likely as atypical. So here are some of those atypical symptoms that a woman may be experiencing when she is having a heart attack, such as, unusual upper body pain and unusual fatigue and shortness of breath and nausea. So I think this matters. I'm hopefully making the point. 51% of our population in the emergency department are women coming to us. It's a majority. And so I'm trying to help get us out of the box of thinking that these things are atypical or niche or unlikely, when in fact it's far more. And we just have a bit to overcome. So our former dean, Dr. Marjorie Jenkins, said that no scientific discovery can save a life without first traversing a learning environment on its way to the patient. So I imagine that most of you are educators as academic emergency doctors, whether that's in the medical school or in residencies, and you are really where it starts. They're interested, but you may have to be like me and overcome what you don't know and relearn. So let me give you those tools to transform. So this is what we've been working on for the last 2 years. And I've been going around the country talking about in the last year is this sex and gender curricular assessment and revision faculty development toolkit. It is 5 steps that we're going to go over and then hopefully have a chance to practice with, and then you have free access to this, and I'm happy for you to share it everywhere to make this job easier. So really the first 3 steps are what are new, and then the final 4th and 5th step are where you get to go back, reflect, and edit. So let's dive in. Our step 1 is using an assessment scale, where you look at your existing materials, and this, I'm going to just say, maybe you're looking at PowerPoints or a presentation that you're about to give. You look at those materials for your sex and gender content and assess it, kind of give it a grade. And so we have 1 through 5, ideally you're trying to get a higher score here, but it's a continuum. Starting at the top, biased information. It's okay, it's no shame. We all have to start somewhere, but this might be an example of stigmatizing, reinforcing stereotypes, or the wrong use of language. Blind, assessing yourself as, okay, this slide is blind, would mean that we're just ignoring any difference in sex or gender, and we don't have any evidence, and it's kind of whitewashed. The third is being aware, where you actually acknowledge there are differences or similarities, or that there is a lack of evidence, but you don't really go further into about why those exist. Moving on up, though, explanatory phase is where you do acknowledge those differences, but you also bridge the gap into maybe some factors or mechanisms about why, because that does kind of clinch for people the idea. And finally, we can all aspire to be translational. And I think that's what matters the most to us is, can we now take this knowledge and improve the care of our patients in regard to their sex and gender by integrating this? So here's an example slide, very typical, showing us myocardial infarction. I'm going to give you just a minute to kind of look over it with that assessment scale in mind. All right, and I'm going to give answers. So here, I would say we did get a point. We are aware that there are differences. Whenever you look at our epidemiology section, we see that more men may be affected than women. But then when it comes to everything else, like risk factors and management, we're pretty blind on those. We're not really going into any further detail. And then worse is we're a little biased. When we look at that picture, it reinforces the stereotype as a typical white man with chest pain and a left arm that's red. Next, we're going to use the checklist on that same little piece of slide or whatever you're working on to teach. And this is going to give us kind of a menu to select from and see what do we have so far and what are we missing and where can we improve. So our checklist here has a lot. Don't get overwhelmed just yet because it's going to be an iterative process and you're going to get better and better about this. But if we use the prior slide, all that we really presented was epidemiology so far, and really that was pretty lacking. I mean, there's no numbers or anything on there. Whereas all of the rest of these options in the checklist, we're checking no for. There's really no difference in physical exam or laboratory or imaging or risk factors, screening, no discussion about pregnancy or influence of sex hormones or access to care. It's a pretty tall list, but I think we can do better than just one. And I'll take a second because I recognize that a lot of my job and a lot of your job may be in the emergency department to teach at bedside. So while I'm pretty focused right now on showing you examples that are slides and PowerPoints, I also want to say that we're putting out there a checklist for clinical teaching also, and I think we'll develop more on this. But if you are trying to incorporate this on the fly in a shift, you can reference this, at least communicating or considering the sex and gender importance of communication with preferred pronouns, and also just recognizing that your gender or the patient's gender, that might influence how you talk, what amount of time you spend talking about things. There's a lot of studies on just the communication dynamics. Patient histories, your medical students are sometimes the best at this, but we can remind all of ourselves to see if this is related, if the sex and gender is related to their chief complaint, do organ inventory checks, and ask about sex hormones, endogenous, exogenous. Like I said, it's becoming more and more common for our patients to be using estrogen and testosterone. And think about the last menstrual period outside of just trying to determine if they are pregnant or not, because that might unlock clues as to how to help this patient in the future if they have some kind of cyclical variation in their symptoms. So I'd say this is the beginning for bedside clinical teaching, and we hope to do more. So as we come back to step 3, this one is a little bit more dense, but this is where I really think you're going to benefit from our resources. We are giving you all the resources that we've got, and there's probably even more out there, but I'm going to show you a website, sexandgenderhealth.org, which already has so much built into it that you can just drop over there and pick a few things, come back to your own presentation and add it, or just add it to your own little knowledge set so the next time you're clinically teaching. Also, I'll show you a textbook, How Sex and Gender Impact Clinical Practice, and that way you can peruse that. This is a textbook that's typically available with your university or affiliated health science library online. So that's how I access mine. And then I'll show you the Sex and Gender PubMed search tool. That way you can incorporate the most recent data because data is exploding. We have more and more research that we could be using and incorporating, and so you can stay at the front of the field. So first, this is our website, not my website, but the website I'd recommend is sexandgenderhealth.org. I'm showing you the slide library bank here because odds are they have something already written by other professionals who have gone through all of the data they could accrue to give you fast facts, on acute coronary syndrome, like our prior example, or asthma, and moving on through all sorts. There are also videos, there are little micro modules, learning modules, and cases that you can review there as well. So this is a fabulous resource. This is the textbook that I was mentioning because, again, you have someone just gathering it all and writing it in a very digestible fashion if you were just starting out and not trying to get too deep in the weeds. Then I would recommend this book. And also Dr. McGregor has one oriented to emergency medicine that's well written. So here you can see, though, hold on. There we go. Cardiovascular disease is highlighted there. And I mean, gosh, if you went through that, you would check every single box on our checklist. You don't always have to. Think about who your learners are and what facts you want them to come away with and pique their minds with maybe, a couple insightful considerations. The good news is there's also at the end of each chapter, usually something translational, because that can be kind of the hardest thing is to imagine now how do you use it for your patient's care. And then finally, this is the PubMed search tool. And let me show you what you can do. This is actually easy to find on the sexandgenderhealth.org website, this string of different sex-based, sex factors, different words to put into your search with acute coronary syndrome or whatever it is that you're presenting and wanting to look, is there new information? Are we up to speed? Can I find something faster? Is there literally nothing written anywhere else and you're looking for brand new information? So you just use the top box to put in what you're interested in and then add our search string below in the query box. And you'll get many hits that you can then sort by years and all that good stuff on PubMed. So you've gotten through the most of it. And now we just have to go back and edit our content and see what kind of changes need brought up to date. So here we have that original slide. To incorporate more information, we went to those different resources. We looked at their slides, we looked at the textbook, we liked a couple of things, and we might split this now into two different slides. And I'm going to assume this is probably for higher level learners, maybe residents, or maybe other faculty, but at least med students can start out with the basics here, which is just a picture of a woman and a man and a few extra symptoms that weren't reflected before. It's not just the burning arm. Now we have some jaw pain, dry mouth, GI symptoms to note those atypical symptoms that a woman may have as opposed to just a man. And then below, I'm sorry, it probably is a little bit small, but we incorporated a lot more information about female-specific factors, about oral contraceptives, about hormone replacement or pregnancy outcomes, and what happens when you're in a hypoestrogenic state, like postmenopausal, to clue people in on that. We also have some of our treatment options or some of the findings that we might find that are different. So in particular, if the patient who's having chest pain, you prefer them to get a cath done quickly, maybe a STEMI, and they're going to cath lab, the woman may end up not getting any stents. And that's no failure of your own or the cath lab. It's because her disease might be different, the way that the plaque is laid down throughout her coronaries, as opposed to a man who will put down large, bulky, easily broken off thrombotic plaques that need stenting. So this helps clue people in that there are some actual differences and some differences in the outcomes as well. So, and finally, to be kind of transformative, I think quite small down there is a analogy up about trying to refer more women to cardiac rehab after men because they have equal benefit and are just less likely to get that kind of care after having their cath and all of their coronary workup done. And finally, that's a lot of information, but we also don't know everything. And so you might come away with your slide not showing a dense amount of new research or new information. It's okay to acknowledge that the research and the evidence lacks and that there are gaps in knowledge and in the field. Learners actually appreciate whenever you bring up that there's limitations. We don't know everything just yet. So never feel ashamed to let them know that we don't know everything. Step 5, our final slide or final step is looking back, assessing, and doing the checklist again to see how far have we come. So looking at that slide, now we know we're more aware, we're acknowledging differences right off the bat. We're not using bias pictures anymore. Also, we're explanatory. We're explaining actual differences between cardiovascular treatments and risk factors between men and women. And we're also being translational. And so this is straight out of the textbook at the end of the chapter, where you can see starting today, you can go ahead and start practicing trying to encourage smoking cessation. It really matters, obviously, for all our patients, but it especially matters in women's cardiovascular disease and postmenopausal women. And they have certain foils, things that succeed, things that don't, whenever they're trying to quit smoking. And I had mentioned the automatic referral pathway. If your hospital can get on board with referring everybody rather than us accidentally introducing some biases into who gets the follow-up care and who doesn't, or who gets TXA, who doesn't, right? Some of these things we could make automatic to be more equitable. And now we're looking back. Our checklist is quite filled out after all of that work that we put in. We are no longer just checking the epidemiology box, but we're covering everything from clinical presentations and risk factors and etiology and diagnoses and treatments, as well as recognizing some knowledge gaps if we don't know them. And I want to say, like I said at the beginning when I first showed you the checklist, this can be an iterative process. You don't have to do everything all at once. Certainly, we are all generally harried for time. No one has excess time. And so, whenever you're looking at challenging yourself and trying to do something new, just bite off a few pieces if you can. Just opening your mind to the fact that these differences are there is a huge first step. Now, see if you can translate some of that to your students. So I firmly believe you've got this, and we want you to have all of the resources that we've been working on so hard. And so we want you to use that. And I'll resend the link here in a minute. And more than anything, I do like to remind people that sex and gender, it does not have to be niche. This is not niche. This is just medicine, as Dr. Alison McGregor would say. She is my mentor, and I will say she's a trailblazer in the field. And I'm very happy she's here at Greenville to help spur us on. But each one of us has to kind of take up the flag and move it forward. So the way that we would do this typically in our in-person workshops, or if you were at a conference with me, is we would pass out our materials and we would go over slides with your partner. I'm not going to break you into like small rooms and make you do that. I would love if you want to volunteer, talk, and articulate, ask questions. As we get into this section, I'm kind of turning it over to you all. Let me first check before we do this slide. We're going to take an example slide and I'm going to show you how I would change it, but I want all of your feedback as well as, if you can, practice with the tools. I'm going to show you really quick to use our QR code. So if you go scan this QR code right now, I realize that some of you might be on a meeting and listening and not going to participate. That's fine too. But this is going to give you a one-page version, and this is going to be all the resources. I'll throw that up there at the end. These resources are kind of built into the toolkit, so hopefully you can access them there. But I'll leave this up for a second, and then we'll switch back to our slide that we're going to fix, improve upon. I would say the advanced PubMed search tool is what I would recommend, because I've realized looking through a lot of the way that we present or like just title research on PubMed, they may not say sex differences, they may just say women or men. So the advanced incorporates a little bit of that. So just to have you aware. All right. I'm going to show you this slide as our example. I hope that you can walk through the toolkit steps. If anyone is willing to point out maybe the obvious. I'm really big into like what kind of pictures you're showing. I think the most obvious thing is that we have a male football player. I mean, they're doing an awesome job in this picture representing ACL injuries. But what if I told you that it's not always football, it's less often male football player that's experiencing an ACL tear, and that it's not actually typically from a tackle or direct contact or collision? It's not the most common mechanism. Maybe some of you have had this surgery yourself. I'll put my hand up for that. Female soccer players are way more likely to get ACL tears. So I think starting right off, there's a little bit of bias and then some whitewashing. There's not really a lot of detail about our ACL injury here. Like I said, please feel free to jump in, but I'm also used to everyone's a grown adult. You may be unable to talk out loud right now.
What's
So
really interesting to me is that first slide that says young athlete and how much that picture primes your like mental imagery of what young athlete is. Like you said, like when you put that picture next to young athlete, like that just makes me think, oh, well, all young athletes are young male football players. That is, it just
yeah.
primes that mental imagery for like future. I mean, I did an interesting exercise with my med students the other day when I was talking to them a little bit about some of the biases, and I just asked them to like tell me the like illness script for a heart attack, like you said, and how many people were imagining a male, and it was 95% of the class or something. But so it's really interesting how these pictures prime them. I mean, nobody ever, I think, told them that. It's just these unintentional kind of biases. It's really interesting.
Right. Yes, I really think so. And if anything, after this talk today, if you just want to look through your pictures and start thinking about that alone, I think that can do a little bit of help. I hope you use more of the toolkit, but certainly like imagery. So my first update naturally was the picture. And thanks, JJ, for mentioning it, right? Like the young athlete totally went in the direction of football all the way. Not a whole lot of females playing football. So now we've updated at least a little bit more about our demographics. And by going to the same resources, pulled these resources from Sex and Gender from an orthopedic surgeon who's contributed to some of that research and write-ups about ACL, like more information, like really more better information about ACL injuries and going into why, like why is this? And there's a bit of research about jumping and landing mechanics, biomechanics being different in young men and young women, and next steps rather than just say, oh, put a brace on it or wear a brace. Thinking how overall we could do better with injury prevention, jump landing training, muscle strengthening. There's a lot of young female athletes out there that can benefit just by you doing a quick kind of flip of the script of what are you showing on your slides and maybe how you're using the toolkit, how you're using some resources to back that up. I'll say I would have benefited from that being a double ACL contralateral. All of this could make my life better. I'm going to leave this on the resources for a second and just kind of like open up the chat a little bit. I have more examples. I have a lot of examples clinically that I can share and that I can go through, but I also like to hear from you all. Part of our development of this toolkit was to sit down with medical educators, and I invited a bunch of emergency medicine educators because we just do it all, and participate in a certain way. And I found that our discussions and feedback were really super key to how we developed this. And also, I can bring out from those chats, like, why is this so hard? What makes it hard for you to do this? It's not easy. We're trying to make it easier.
So I'll just pose my one burning question. I did a little bit of work with ASAP and some of the other organizations about like the race and science kind of statements that we did. And I'm wondering what your opinion or recommendations are for best practice to obtain sex and gender in research, only because you mentioned a lot of the hormonal differences. And then if you ask someone their gender, you're going to miss some of the biological sex. But then I worry about asking someone their sex and misgendering them. And I just struggle with what is the best practiced way to do that without making it a 25 question thing about every hormone exposure and all of those kind of type things in large research trials to obtain it and then report it.
Gosh, yeah, it's a good question. It's a big question. Let me see if I can try and do a little justice or redirect me if you're like, no, this is the part I want you to get to. Okay, this is going to be actually a take on it. I think there's so little happening, or like we can come so far from so little so far. Because so if you look at the research, people are using male, women, men. They're just throwing these terms all over the place. They're saying that they're reporting gender, but they're not. They're actually saying, they're doing sex. It's a minefield. That's why I start this talk with everyone. I've done this to pharmacologists and medical educators and emergency doctors with the whole sex and gender because it is really complicated and it's hard to get it right. So starting a little bit with terminology and then kind of like in the design, I think maybe you were asking about like best practices in research in particular or for education, like or patient encounter.
I was more thinking along the lines of the research. I think we can teach people what sex and gender are, but you had mentioned, go into the research to identify this stuff. And I find what you have so eloquently stated, which is that like, I mean, I do this when I review papers all the time too. People report gender and then report male and female as the gender and then sex and man and woman. And it's very hard for me to elucidate, like, how did you actually like
Yeah.
obtain that? And I feel like they're not always accurate in what they're reporting. They just pick a term
Yeah.
and use it, and it may or may not be the term that they're intending.
Right. And that is the problem. I mean, we're like trained professionals and yet it's hard to do. Yeah, most of the time when you actually like read it, they're just reporting like the sex that was listed in the EMR. And like, is the EMR fancy enough to have given you, I mean, some of them are, you can see what the patient's gender and, if they are transgender, you can, what their birth sex, you can see a lot of those details. But I don't think most people are pulling the data like that. They're just pulling like one and not the maybe not the other unless it matters to them. So most of the literature that I've gone back and looked at, I'm like, oh, they're just talking about the reported sex just on the EMR, and the patient was never part of that conversation about anything else. That being said, I understand a lot of our research is kind of like retrospective and we're using EMRs for that reason. But I think if we're clarifying that a little bit better, or just going into your research project thinking like, oh, is this a variable that I'm going to want to use? And yes, maybe I should disaggregate my data. And when I get to the very end of like my discussion, talk about it as a primary outcome, like that, oh, there were differences. Maybe they weren't immediately transformative, but to report them anyway so that we have more knowledge just about the potential and the possibility. Like the prior research about emergency medicine, only 2% had it in like the outcome. If we directed a little bit more research specifically towards exploring this, I think we'd have better information, obviously.
Yeah,
More
thank you
information.
so much. Yeah, I appreciate your expertise. I'll throw another comment out and feel free to just leave this one hanging and not respond to it because I don't want to hijack the whole conversation. But the one thing, like again with race too, that we find is that the race that's put in the EMR is whatever the person registering the person like thought that person's race was at the time that they like registered them. And I think that happens probably a lot with sex and gender. I think sex gets put in a lot and it just like people just put in whatever the registration person like thought that person's sex is by looking at them, and which, as we know, may or may not be necessarily accurate. So just one other kind of thing to throw out there, but feel free to continue on
Yeah.
and just leave that one hanging as a unsolved mystery for the future.
Certainly possible. I will say one of the examples that I have used, given the talk before, is the time that my medical student took the best care of a cisgender patient ever. And it was because that patient was labeled incorrectly in our EMR, which does have like a little more descriptive, I guess. We use Epic and you can kind of see like, okay, this is what they prefer to be called. These are their pronouns, that might be in there. Well, somehow a misclick occurred. And so a woman who was presenting to us as a woman with chest pain and labeled incorrectly in the system. And my medical student took an organ inventory and asked about hormones. And it turns out that she was young and had a hysterectomy, including removal of her ovaries, and at a younger age, and then was on estrogen supplementation that was not recorded in our medical record for whatever reasons. And that patient totally got the workup for PE and had one. I mean, all of you probably would have gotten there, and scanned this patient for her pulmonary embolism and chest pain. But it was funny that specifically the student took so much extra time and then did an excellent job arriving exactly where we needed to be by incorporating a little bit of extra, deliberation, like details, just in collecting up front, like I said, with the organ inventory, with the estrogen use. So those are small things I think that we could do a little better, that also the system could do better, have it more in the medical records. My tangent is that I ask now so much more than I did before. And I find that a lot of my male patients, a lot of men that I see, are using testosterone. And it was not brought up until I specifically asked, just whether they assumed that it would be in their medical record, if they didn't really think it mattered, because yeah, like what kind of information is out there for them. So I think that we can do a better job taking care of everybody by incorporating this. Our minority patients, our majority patients, everyone can do better. But super key is, I think another thing from the focus groups is, I know you all are very busy and that maybe you are also doing research here or there, or you are doing specific medical education. I really want to like tap your brains and say, I know you have a lot on your plate. If you can incorporate a little bit of this consideration into what you are teaching, it's huge. The medical students are so eager and willing and ready to hear it. And I believe it will translate if you bring that up in their medical education now, for them to be more inquiring as they move through their future training and as physicians later on.
Yeah,
to just provide a little add-on to some of the comments or submissions that you had made. Well, quality improvement in our processes is going to come over with time, especially following webinars like this, and shaping our perspectives as to whatsoever we document, the way we relate with patients, the way we administer medical education, because orientation, especially gender orientation or sex orientation, either from individuals or in the context of the person that you happen to be relating with, is shaped as a result of a lot of factors over the years. Our experiences, our perspectives, our personal gender identity has a lot of roles to shape as to whatsoever we relate with, even with data of patients, especially in recordings. So this webinar is quite timely and quite informative and educative to shape perspectives of individuals as to whatsoever they do in their various domains in relating with gender and sexual orientation as it may apply. So thumbs up, Sido, thumbs up.
Thank you. Appreciate that. And I see someone chatted about the Sager guidelines, and I never know if I'm saying it correctly, if it's Sager or Sager. I'm going to apologize. But yes, there are guidelines out there to help you as you're designing your research, but also as you're assessing systematic reviews and research studies to see if this is getting incorporated early on or too late. So I did a little review with some medical students and other faculty at Emory about Sager guidelines for for posterior stroke, and we went through all of the old neurology literature that the GRACE guidelines were using for dizziness in posterior stroke. And it was shocking. It's not shocking to me anymore how few, I think it was less than 30% reported males and females in their research study, or the number of times that the wrong terminology was used. Like, they say that they're asking the gender, but I'm like, yeah, but you probably didn't. Like, based off of the way I see you acquired the rest of your information, like, you weren't doing that. And that's fine if you just represent it correctly. And I like our emergency medicine research, very few had anything in the discussion or the outcomes about some of the sex differences, but there are differences, especially in dizziness in young females with posterior stroke and vertebral dissections. I mean, there's kind of like a nice, rich bit of information, but it was such a minority of the review that we looked through using those guidelines. So, like I said before, we have a really long way to come, but it should be exciting because even if you do a little bit, you're doing more than what has been done. Just incorporating a little bit of this, each time that you look through maybe your PowerPoint that you're about to give, maybe you do the same one every year or similar, is run back to some of the resources and maybe pull a few extra things that you didn't know or that could matter, and it might lead you in this battle.
Jenica, I just wanted to add a comment. First of all, I joined a little late, so I missed half your talk, but from what I heard, this was amazing. Thank you so much for sharing all these resources. This is definitely going to be impactful in my education to my residents. But I wanted to make a comment about specifically your points about imagery and proper representation through images and educational tools. And specifically, my research is primarily focused on cardiac arrest. And only in 2023 did, manufacturers start to build and become more publicly available female breasted mannequin. Mm-hmm. And so that was, a game changer for us here in Illinois. And we've incorporated those breasted mannequins in our community CPR trainings. And every time we go out, the lay public, they're just shocked that, and they're so appreciative of the fact that, wow, there's actually, a representation of a female or more anatomically appropriate female body. And so that's been some of the incorporation implementation in terms of just community-oriented research that we're doing. So makes a big difference.
I love that you brought that up because that's another thing. I teach this elective, the sex and gender elective, to our fourth year medical students. And we talk about how lay people are less likely to start CPR. Like they will recognize that they can start CPR on a man who's laid out and unresponsive, but a woman,
Yeah,
it
there's
doesn't
fears.
trigger. It doesn't
Yeah.
trigger the same response or as quickly, or they're afraid that they could be accused maybe because there are breasts that exist, you know? So that's a really good example.
Yep, appreciate it. Thanks.
If I could make another plug, just yes, we hope that you can use these resources again and that you can reference this webinar, send more people our direction. If you want to send me an email to follow up or chat or collaborate, I am more than happy to spread the word and keep talking about this all day. I think we're at 4 o'clock. So I was going to just say, like, next time that you're working on something that seems really niche, like maybe you're looking up like one particular clinical syndrome, try this out, just plug this in, see if you get any hits on sex and gender differences. You know, even if you're not going to go through the toolkit, just see what's out there, and it can be pretty exciting. That's what I have my medical students do every single shift that they come and rotate with me, and every single case I'm like, we're going to find something. So plug it in and use this information as you go forth. All right, well, thanks y'all. Like I said, happy to answer questions or be in touch with you online in the future. Thank you all.
Okay, bye-bye.